Yes, we thought we'd start with something light, just to... Thank you for that introduction. Before I start, I want to say to the Spaniards in the audience, lo siento for my accent and if I speak too fast. And I say to all the non-Spaniards in the audience, I'm sorry for my accent and if I speak too fast. Look, it's perhaps the greatest understatement of my professional life to... Oh, that's much better. Thank you. It's a very great understatement of my professional life to tell you I'm extremely honoured and humbled to be here to witness the start of a very new and promising development in hospital in the home. I've worked, as Itamar said, in this area for almost my entire career, and to be honest, I never expected something like this to happen. I hoped, maybe, expected no. So I'm very pleased to be here. This is us. This is the hospital in the home profession. Our professional lives in hospital in the home can be difficult. We are isolated. Our colleagues are few and widely scattered around the world. We're misunderstood by our institutions and by some specialist groups. And while our patients might love us, they've generally never heard of us before they love us. We have no journal. There are only 3 or so... Ooh, go backwards. There are only 3 or so national societies that I know of in the entire world. And mine is as far away from here as you can be. And we have no international society, obviously. So this makes meetings like this all the more important. All our meetings are important, especially this one. It means that because we are few, we must make the best of our contacts and the best of our opportunities to help each other. I can reassure you that some of my most encouraging moments in my professional life have come from visiting fellow units in other countries, not because of the things they were doing differently, but because of the things that we were doing that were the same. It was a feeling, I imagine, like finding your brother and sister after being separated at birth. A sense of familiarity and solidarity that, after all, we are seeing things the way others do and we are doing the right thing. I had that feeling visiting Torino and Dr. Tebaldi, who's here today, from where many of the randomised trials have originated in our field over the last 30 years. I got that feeling also in Paris when I visited Laurence Nevers and Michel Camon, who come to work every morning to look after 2,000 patients in hospital in the home in Paris. And I got that feeling as recently as yesterday when I went to visit Manuel Rubio at the hospital in the home service at the Hospital Torrellón here in Madrid. These experiences are combined with my contact over decades and with the many teams in Australia and New Zealand hospital in the home units. The experience, the skills, and the tenacity of the people working in our under-recognised field is very wonderful. And if nothing else, this meeting is about embracing each other and recognising those skills and contributions. But this forum must be more than that. This is the right place for discussing advances in our field and for discussing issues of identity in our emerging specialty. All progress needs momentum. Hospitals have experienced waves of momentum in other fields, like intensive care and emergency medicine, both of which are really only barely more than 40 years old. Both of which areas were triggered by and then further driven by technology. Many of us and many others believe that hospital in the home will become the next specialised hospital service that will drive developments in hospital medicine into the next few decades. And by using increasingly portable hospital technology, it will be one of the things that define us. And we are at the right time in history for taking advantage of portable hospital digital technology. The patient experience of hospital in the home must be at the core of what constitutes what we do. There are growing numbers of patients who need hospital services but who do not want what are being offered to them. If we are offering them a substitute hospital admission, it will be patients who need to understand what that means, and it will be patients who will decide whether they accept it or not. Hospital in the home care must be conducted so that it is evidently comparable in process and safe and effective in outcomes for patients compared to hospital. If we succeed, we will be the first hospital service that genuinely responds to the growing call for hospital medicine to be more patient-centred. In this room, we know that traditional hospital care is not patient-centred. I know that the delivery of hospital care is complex and difficult and expectations are high, and that this determines the way hospitals respond. But it is in many ways a gentle joke on the community and to patients to suggest that it is or ever can be truly patient-centred. Hospital in the home units are in a position to show hospitals how that can be done and delivered. Let me give you an example. This young woman with advanced inflammatory bowel disease, adenocarcinoma of the colon, multiple fistulae, peritoneal infections, who basically could no longer eat or drink, refused to have any further treatment in hospitals. She hated them, even though she relied on them, because she spent so much time in them and understood all of their drawbacks and problems. She did not consider treatment to be worthwhile if it meant more of her life in hospital. She begged for treatment at home from a very doubtful specialists. We took her into our care where she required not just one, but many hospital-level interventions and all at the same time. TPN, IV fluids with either magnesium or potassium at times, intravenous antibiotics, some intravenous chemotherapy, and even her paracetamol and her ondansetron had to be delivered intravenously, as well as the management of her abdominal and rectal fistulae and her sinuses. She required all the traditional skills as well of nursing and medical care that we find in hospitals, as well as the technology required to deliver that care. We can offer sick patients with a wide variety of backgrounds and needs the opportunity to have input into their care using the various technologies and people that are made available to us. We can discover, negotiate, and deliver solutions to them and their families to be happier during their acute treatment. It's our communities and our patients who, in the end, will determine if our service is worthy of growth. But to ask for hospital in the home, they must know what it is. We must express a clear vision of what we are and deliver on that vision, and then patients will respond. When I was young and stupid, I thought that hospitals would be forward-looking, ready to embrace and examine strategic shifts in the organisation of care and the application of technology. And I was wrong. Every move forward, every single one, even ICU, even emergency medicine, has required committed clinicians to drag hospitals inch by inch to a better vision of themselves. When I graduated, in fact, there was no such thing as an emergency medicine specialist. It has taken them decades to achieve the status of a specialty hospital service. And sadly for us, as hospitals have become bigger and wealthier, more complicated, they are harder to drag than they have ever been before. So if we're to generate momentum, to demonstrate our value to the community and convince the unconvinced, we have to address some difficult issues among ourselves, issues that our detractors will raise, and one of the most difficult of those is the title of this presentation, and this is where I could go from being your honoured guest to your unwelcome visitor. I'll take that risk. There are many reasons to address this question now. We've talked about the need to explain what we do to our community. We must have a clear focus so that developers of technology understand what we do, so that they can introduce us to current hospital technology that exists and introduce and better yet develop new technologies around our focus on acute home care. If they know that there is a market for this, then they will respond with interventions that we can't imagine yet. And of course, we want those industries to support our meetings and our professional development as well as our clinical practice. We must also, because we need consistency, to promote our services to our medical colleagues. Wait a sec. Yeah. If I can recognise an intensive care unit or an emergency department in Madrid or in Melbourne, then so should I recognise a hospital in the home unit in Madrid or in Melbourne. Our colleagues must know what we do in order to make referrals and integrate us into their hospital work. And they are long accustomed to international consistency in the core elements of their specialty practice. We must be able to communicate our role in the system to attract young, enthusiastic doctors and nurses to work in hospital in the home. We need to answer the question so that we can seek reimbursement at levels that match our vision. And finally, we need consensus we need consensus also so that our research and development arise out of a common understanding of what it is that we do, what our intervention is, and so then our findings can be generalizable. Finally, there are many countries who don't have hospital-in-the-home services, and by establishing some consensus now, we offer them a journey with a map, some guides that perhaps those of us in established countries didn't have, and hopefully will help them. But to describe something new, like hospital-in-the-home, is quite difficult. And finally, if we don't decide what it is, it will be decided for us. So, for many of us in this room, we could answer the question by saying, well, we know hospital in the home when we see it. And I think that too sometimes. But unfortunately, that's not good enough. I know what a kangaroo looks like, but it's very hard to describe it to someone who's never actually seen one. And even if I show you a picture, it doesn't completely describe how it feels, how it moves, how it lives, what it tastes like. So where do we go in help to find this definition? Do we go to the research literature? It would be nice if we could enter hospital in the home as a search term in any literature engine and have all our relevant papers appear together at the top of the list. But this is what you do if you put in hospital in the home into PubMed last week. You get 356,000 responses and a long search down that list to find something relevant to what we actually do, or someone who wrote a paper who's in this room today. Sadly, for those of us who've tried, the research literature is not very useful to answer the question of what hospital in the home is. You cannot only read your way into a functioning hospital in the home service. For the most part, researchers use the term loosely, and in many cases, they don't define the model at all in their research. This includes the Cochrane reviews, which really only hold a mirror up to the inconsistency of the definitions in the literature, which I guess hold a mirror up to the inconsistencies in practice. What about funders of hospital in the home? Funders, you might expect, have defined what they're paying for, so they should know, hopefully, what they're paying for. But there are variations in all forms of hospital practice between countries, within countries, and even between hospitals in the same country. We've all established our programs in the context of our own health systems and hospitals, and in what has been historically offered to us as reimbursement. We then develop our models, we're close to them, and we usually defend them. But where funders have responded to individual advances in hospital in the home, it can be worthwhile to examine what they've done. And my home state of Victoria is unusual in the world because public hospital in the home care is funded at exactly the same tariff as inpatient hospital care. As a result, over time, we've established guidelines for hospital in the home that are worthy of your attention and can be found at that web address. I'm not going to go through that 44-page document, but I will address some of its features soon. But in summary, the guidelines state that hospital in the home is hospital substitution, and that the standards for hospital in the home admission are the same standards as for any hospital admission. They do include some specific inclusions and exclusions, which I will point to later. That's the funders. What about our professional groups? You would think that defining hospital in the home is a core duty of the professional societies. One of our national societies has sought to define hospital in the home simply. The French Society of Hospital in the Home has a definition of its website. It states that, and I'll read it, hospital in the home hospitalisation can prevent or shorten a hospitalisation. It ensures in the home of the patient medical and paramedical care, continuous and coordinated. HID care is different from home care because of its complexity, duration and frequency of visits. And finally, and I think most importantly, they've tried to define an organisational context where they say HID establishments are health institutions subject to the same obligations as hospitals. So this is a worthy definition and again one that I'll draw from later. Other societies, such as the Spanish and mine, the Australian, have been less clear about providing a clear and concise definition of what hospital in the home is, for reasons of historical context, I presume. Okay, so there are some resources and there are some gaps. Let me try to take a combination of these resources and acknowledge the gaps, fill them in with some collaborations and some experience, and suggest some definitions. So here we go. Hospital in the home is a direct substitution for hospital care. It's an acute clinical service that takes staff, technologies, medication and skills usually found only in hospitals, in acute hospitals, and then delivers that care to sick people at home or in nursing homes. We can also further seek to define hospital and home care by describing the technologies and the medications which are inclusive of hospital and therefore hospital and home care. So the pharmaceuticals, the pumps, the diagnostics and the venous access that are found in hospitals or can be specifically designed for hospital and home care can define hospital and home care. We can further define hospital and home by specific diseases themselves or their interventions that go with them, a kind of DRG list of suitable conditions. There are many specific types of treatment that are and can be delivered by hospital and home. Some of these interventions will be described and presented throughout this meeting, so I'm not going to go through all of them. But in general, these are conditions which require treatment in hospital because they require the technical input and the nursing and medical skill that is beyond the scope of community care. Expert, continuous nursing and medical care, hospital drugs, hospital technologies. The care is often directed and referred by hospital specialists. The patients we treat can be at least temporarily frail or weak or febrile or immunosuppressed or have a variety of other problems that have to be managed during the course of their care. Or sometimes they're completely well, they're looking after themselves in all respects other than their professional care. Hospital and home patients must have priority access to return to hospital in the event of deterioration. The greater the complexity of the hospital and home service, the greater the complexity of care it can provide. So let's kind of summarise that in a list. And it helps to think about what it is that we expect in hospital care when we're thinking about hospital and home. So again, like a hospital and home care is subject from an institution that's subject to the same obligations as a hospital. It's specialist directed. It's wholly responsible for the patient. It provides care on a continuous 24-hour basis. It provides all medical, nursing and pharmacy care and therapy during the patient hospital and home admission. It provides that care at home. It has a distinct episode with a start and an end, and patients have priority to return to hospital in the event of deterioration. Okay, no one's left the room yet, so that's good. They might now. It might be useful to think about what hospital and homes typically don't do to define what hospital and home is not. That's sadly important because there are many groups who want to claim the label of hospital in the home. It sounds attractive. It promises so much. But the presence of services labelling themselves hospital in the home when they aren't threatens the position of genuine hospital in the home. It affects the attitude of funders, who in turn will reduce tariffs if they are offered lower levels of responsibility, staffing and technology. So what isn't it? It's not home-based primary care and it's not community nursing. That's not to say those things are not important. It's just to say that not all healthcare delivered at home is hospital in the home. Hospital in the home is not OPAT or any other hospital-based program that delivers outpatient care to the community. It's not an early discharge program or coordinated care program. In those interventions, the involved service is not primarily and totally responsible for the patient's care continuously. They're usually not comprehensive and they usually don't have an end date. And they don't generally provide after-hours care. They don't necessarily provide hospital-level care either, even if they meet their aim of reducing the frequency of hospital care, as is often their stated goal. And in my view, it's not self-administered care. So that's a pretty long list. I hope I haven't upset too many of you. There are times when I think it's just as simple to say that hospital in the home does the things that both hospital specialists and GPs think that we can't or shouldn't do at home. In broad terms, we have, or we will, permanently and profoundly change the way some hospital specialist services are organised and delivered. They don't know it yet, some of them. The specialties who must respond to our presence and growth are infectious diseases, oncology, hematology, cardiology, immunology, palliative care, paediatrics, geriatrics, transplant medicine, and post-operative medicine and surgery. Emergency medicine and general practice will need to consider a new place to send their referrals, and the list is growing. In my view, this is the sort of model that should be established, researched, costed, and if genuine substitution is to be delivered. To provide this sort of care, hospital in the home requires significant funding. It might be less expensive than hospital care, but it's not significantly less expensive than hospital care. The studies that have costed this sort of hospital in the home program talk about an efficiency of 30%, not 80%. The cost of a new bed in a hospital in the home, however, is much less expensive than a new physical bed. So just to show you I'm not an absolutist, there are some things I'm not so sure about. Should hospital in the home be delivered only by hospitals or a service legally defined by a hospital? I think so. I believe the French hospital in the home definition that says that hospital in the home should be delivered by an institution subject to the same obligations as a hospital is an excellent way of answering that question because it allows non-hospital institutions to participate in hospital in the home care. Should patients in hospital in the home receive their specialist medical care in person at home? I think so. I think the ability for hospital in the home to provide the physical presence of a doctor at home is a requirement. Of course, it can include remote healthcare by a doctor, but in my view, not to the complete exclusion of a physical medical attendance. What should we call ourselves? The words hospital and home are very common and are very commonly used together for a variety of reasons. Is hospital in the home the right term? I think so. It's now used identically in the Australian, the Spanish and the French health systems and literature. I think a change would waste the last 20 years of publications and policy. I realise it's not a sexy term, but nevertheless I hope that experience is of value, especially to our American and British friends who are just starting their involvement in this area. So, I hope these thoughts are not necessarily new or too shocking to you. After describing to you the pride and achievement in opening this first international meeting on hospital in the home, I wonder if we should all be a little bit embarrassed at how long it's taken us to get to this point. In years to come, people might wonder what the heck took us so long. Some of that delay is not our fault. It's a great irony that while many of us feel undervalued and hidden from view in our health services, yet because we are so few and therefore we are so busy, we can barely draw the resources to conduct our national meetings, and certainly without help could not organise an international meeting. So maybe it's taken us so long because we realise we have much work to do and that we're fearful of the extra work in starting that journey. So I'm going to use the cliche about Spaniards having a long history of sponsoring voyages into the unknown. And I would suggest that we've only just started on that journey, and I hope that you take this presentation in the spirit of that intention. I want to thank you for attending. I need to thank Itamar for pushing this initiative because he's still young in hospital in the home years and enthusiastic, so good for him. I would like to thank Beatrice and Bruce for their assistance and support, and the people from Kennis who have persevered, with politeness and hard work to get us here. I want to thank the presenters and delegates from Australia. They've made a major investment in time and expense to support this meeting, and in fact have also supported in some part the translation service. I've only on rare occasions been to conferences with thousands of people, and the truth is I don't like them that much. But I'm always curious about how those meetings started. In fact, I often can't help imagining the beginnings of anything, which maybe is why I'm in hospital in the home and not cardiology. So I'm happy to be here to see how the first International Hospital in the Home Conference went, and perhaps in years to come when there are thousands of people attending this meeting, I'll know that we here hold a special bond between us in knowing those humble origins. Now I've not spoken for 45 minutes, you'll be pleased to know, so that we can have an opportunity to discuss these issues in some detail here on the floor and also afterwards. Thank you very much for your attention.
Gideon Kaplan from Australia. Michael, thank you for a very interesting talk. However, your definition of hospital in the home contains a fundamental logical flaw, because you say that hospital in the home provides care that is a substitute for care in hospital. And the type of treatments that you describe are not all that hospitals do to inpatients. So many hospitals, for example, provide rehabilitation care to inpatients. So why cannot rehabilitation care at home as a substitute for rehabilitation care in hospital be part of hospital in the home? What you define as hospital in the home is a very narrow component of all the things that are done in hospital. Hospital at home or hospital in the home should embrace the totality of hospital treatments and deliver them at home. Thank you.
Thanks for that. In terms of the definition being illogical, if there is acute rehabilitation that would otherwise happen in a rehabilitation hospital, then I guess the same principles apply. It's defining the line between acute rehabilitation and long-term ongoing rehabilitation. And if the rehabilitation specialist can define that, then I don't really see how it's illogical. If it's the same inputs provided by broadly the same staff to the same kind of patients, then there's no problem with having rehab under the umbrella. Clearly, I've not had experience in providing rehabilitation at home, but I don't see any inconsistency with that.
Okay. I think we have a question here. Gentleman, yes? Okay. Sorry.
Okay, I'm Mufid from Home Care, Klalit, Israel. What you said here is home care, home IV or a hospice at home. But hospital at home, I thought that patients that you take from emergency room, acute patients. Home care is subacute and chronic patients. And hospital at home supposed to be acute patients that you take them from emergency room.
So definitely there's a group of patients who are suitable and eligible for acute hospital and home care who are referred from the emergency room, correct. But there are also people who would otherwise have ongoing stay in a hospital bed, who are still acute and would stay in that hospital bed, who can come to hospital in the home at some part of that hospital admission from the wards. So the sources of referral into hospital in the home would be, or sometimes directly from the community without necessarily coming into the hospital at all, from the emergency department and from hospital wards as well. That's fine. That's where we would expect to generate our patient groups.
Okay, the question now, yeah, the lady.
Hello, Penelope Bryant, Australia. Hello, Michael. I absolutely think it's fantastic that you've come here and challenged us to really think about what hospital in the home is. So I'm going to challenge you with one of your definitions as well. So you talked about it being home care that's delivered in the home or in the nursing home. So in paediatrics, one of the things we really try and do is get kids back to school. And so we often deliver our care for children who are basically back at home but are also back at school. So what do you feel about home care in the school?
Well, I mean, you're treating them at home and they're going to school as part of that, right?
That's right.
So, look, that's a question for a risk assessment rather than absolute kind of barring of an activity or another. I guess someone else would say to me, you know, can you treat someone at work, for example? I mean, I'm always apprehensive. I wouldn't want to say that all children can go to school when they're being treated in acute setting. I guess I'd say to you, Penny, if a paediatric patient was in the ward at the Royal Children's Hospital, would they be allowed to go to school? And I guess the answer probably is no, but that's what's different about hospital in the home. We account for people's individual circumstances and we make a more patient-centred response. So the answer is they can go to school if you think it's safe enough for them to go to school.
All right, well, thank you. Actually, we do have a school at the Royal Children's Hospital for kids from the ward to go to school. So you're right, it does replicate the same environment.
My name is Jörgen Nordenström from Karolinska in Sweden. We're in a planning phase to start this service. Very frequently, when we talk to colleagues and administrators, they tend to want to provide less sort of standards for the hospital at home. Say, do you really need that? Can't we just go home to the patients? Do you really need a specialist? Why can't you have a GP or resident or intern? And it goes on and on and on to the point where there's nothing left. So how do you keep up the standards and the notion that this is not a simpler way of hospitalization? It's in fact just that.
That is the hardest question that I'm going to be asked today. I mean, look, if you start with a very clear idea of what it is that you want to deliver, and you explain to those people that this is a substitutive service, show me what you're doing for these patients currently in the hospital now, and they have a specialist, residents, nurses, they have a variety of resources, and you explain to them that there is no difference, in fact, in those inputs. And in fact, in some ways, organisationally, it's more difficult for us to deliver that care at home than it is in the hospital, so the resources still have to be there. It stems from an idea that as soon as you take, some people have that, as soon as you take care home, it's automatically incredibly cheap. It's barefoot medicine. And in fact, it's the opposite. The technologies that we need to use and the skilled staff that we need to use have to be better because we're not there all the time. Whereas in the ward, there's someone there all the time. It does help if you have a clear idea. If you walk into that room and have that discussion without having a clear idea of what it is that you need to deliver that service, you will be nobbled, as we say in Australia. They will undercut you. So the best defence you can have is to have a very clear understanding of what it is you're going to deliver and to put the patient's safety at the highest priority. And look, you're not going to win every battle. It's just not the case. You're going to have to find as many allies as you can, both clinically and in the funding bodies, to assist you. And I wish it was a smooth path, and it's not a smooth path. I've indicated that. It's going to be a very difficult job. But be clear about what it is that you want to deliver and how you want to deliver it. And if you don't accept that reduction in standard, if it's kind of yes or no, but not, you'll do what you want, what you feel needs to be done, but you're not going to accept a compromise early, then at least they understand that you're serious. Good luck.
Carmen Hernandez, coordinator of home hospitalization in Barcelona Hospital Clinic, University of Barcelona. Thank you very much for this clear presentation, and thank you to be here. You talk about the skills of the medical and nursing to be involved in the home hospitalization. I completely agree with you, and I ask what do you think to organize some extra education for the professionals to be involved in the home hospitalization program? What do you think about to organize some international master for these professionals? And I think this is a good opportunity to talk about this. That could be a frame to decide what type of professionals should be the best to be involved in the home hospitalization program if you want to increase our complexity and to define to separate about the home hospitalization and home care or other activities to be at home. Thank you.
No, it's an excellent comment. We, at the moment, rely on accepting doctors and nurses to our service and teaching them individually how to do what we do. We don't have a curriculum, we don't have postgraduate training in what we do, and you're right, that is a great shame. It's a shame that we don't do it, at least in my country, at a national level, and whether it was at an international level, it's also a great shame. We need to work on that. We need to have a set of skills that we agree people who work in our area should have, and they do need to have those skills, and they need to be more senior than the average person who works in a hospital, because, as you know, when they go to a patient's home, It's just them, one pair of eyes, and if they don't see it, it won't get seen. So it's very important that we teach our staff to be very highly skilled in areas where in the hospital they may not be. So I completely agree with you, and it is a failing. And if this group or any other group can find a way of overcoming that, it would be a major step forward.
Hi, Michael. David Levine from Brigham and Women's and Harvard Med School. Thank you so much for your really inspiring words. I wanted to ask you a question about the contextual nature of the definition, because hospitals are very different things all over the world, right? Lengths of stay are incredibly different, oftentimes by an order of magnitude in parts of the world. Resources are different in hospitals. And so if the definition is substituting for that, I wonder how you think about the relative differences so that we can all be unified in a definition. If we do want to substitute, I wonder how that substitution needs to be based on what a hospital looks like where that individual practices.
Thank you. But that's kind of, I hope, that the impression I was giving, rather than being prescriptive or more prescriptive in what it is that we do. Because what's substitutive for an acute hospital in Paris or in Stockholm or in Sydney is very different. The people who are in those hospitals are in there for completely different reasons. So I don't want to tell a hospital in Stockholm or in Paris what should or shouldn't be in hospital in the home relative to my hospital in the home. Now I know that makes it difficult for reasons you just said. The context is difficult, but hey, hospitals have been doing that themselves. They don't care about that problem. They seem to just roll on, right? So why do we have to get kind of tied up in knots about that? Wherever you are, if we're about substituting for the care in the hospital, and that might mean different things in different countries. And certainly that discussion is obviously easier in a national meeting. At an international meeting, you know, that's the answer, I guess.
Hello, Professor Montalto. I'm Zhang from Taiwan, and thank you for your inspiring speech. But I want to pose a question about hospital at home exclusively. Is it very exclusively only run by the hospitals? Of course, my answer is not. I think that maybe there's a difference between that. You mean in your definition, hospital at home is run by a special department in the hospitals. But sometimes if we run by, for example, a home healthcare team who cares for patient for continuous care, and sometimes chronic care, sometimes acute care, because in my opinion, if the hospital at home success or not depends on the trust between the patients and the family and the doctors. And if the trust is not solid enough, especially in the acute care unit, you mean that sometimes we will become from the honored guest to unwelcome visitors. I think that maybe if we can change a little bit the definition and think that hospital at home may be a part of the program run by the home healthcare team, maybe in the hospital, maybe in the clinic. If it's a better alternative or not, this is my opinion. Thank you.
It's a good opinion, it's a valid opinion, and I guess that's why I said, you know, I'm not exactly clear on who should run it, but there has to be, it is about trust, and it is about, if we're going to substitute for hospital care, there has to be trust in the deliverers of the service by the hospital too. So you've got patients, you've got the community, but you've also got the hospitals, and the hospitals have very blinkered views about the delivery of care that is genuinely substitutive, and you don't want them to be alienated from this movement, because it's about them as well as about us. So I guess what the French definition is doing is leading us to say, well, you don't have to be in a hospital, okay? You don't have to be a hospital-based service, but you have to be a hospital-like service. Now, I guess my opinion is, if you start to mix hospital in the home with community care and chronic care in the same organisation, you're a very good organisation if you can make those cuts. But I'm not excluding it, and I'm not excluding it at different phases. It's just that you have to work like a hospital-like institution rather than, I think, a primary care-like institution, even though you're not in a hospital. Is that clear?
Okay, let's take 2 more questions and then we move on to the next session.
Thank you, Michael. Omri Shental, Sabar Health, Israel. How do you attract quality health professionals to do this hard job we're doing?
Yeah. Look, that's a good question, because we need to have people who are a little more senior in their professions, a little more experienced. But I think that you will find within hospitals there is always a group of staff who have swallowed the dream, and then the dream's gone a little sour for them, and they're looking around for an alternative, and they are willing to take us on our promise of maintaining their acute hospital skills, but exposing them to a world that's outside the hospital, that's a little more personal and a little more rewarding in some respects for them in terms of their practice. And so they try. Unfortunately for us, it's a question of try and see. Some people try and love it. Some people try and hate it. But I don't know that that's particularly any different to any other kind of specialty service within the hospital. But we don't have more than that. I think the promise of what we're delivering is there. And also, it is about momentum. So within the hospital, people are attracted to where the growth is, to where they see movement in terms of resources and in terms of research and in terms of just growth in the size of the unit. And if they see that hospital in the home is taking steps forward, then people are attracted to that kind of situation, and they come. You build it, they come.
Hello. One question. I'm Nectarios Manatos from Greece, and I want to know if there is any roadmap for patients, professionals, healthcare systems, for the government to move from hospitals to home care system.
Did you say roadmap?
Yes.
So it's. I think that there is enough out there for you to always be able to prepare a submission around a model of service delivery and around the costs that go with that, based on some of the people who are in this room who've produced that work and who certainly have that experience. So you can talk to them, which I think is better than necessarily reading what they've written, and you will be able to put together a package that you can then modify to your purposes in terms of a roadmap, in terms of what could be the basic requirements and inputs to start a service from scratch. Then the hard work starts actually after that. But there isn't somewhere where I can say to you, go to this website, read that book, there's your answer. But some of the answers to your question are in this room, and I suggest you take advantage of your presence here and get it.
Hello, thank you so very much for setting the scene on the topic. I think while I was listening to you, I had so many questions popping up in my head, and at the same time, your presentation was addressing some of the questions we face, because I think I work for actually what you would call perhaps a community care organization in Switzerland, but we do have a hospital at home unit. And I want to echo some of the questions that were raised by our Taiwanese colleague. My question is about the coordination challenge. The Minister of Health of Madrid was talking about borderless and integrated care. If we have to define on the one hand who's doing what and who's intervening when and for what in the journey, in the patient's journey, then how do we ensure that care is coordinated and that information is shared between the different actors?
The same as now, because
well, in our case, it doesn't really work very well. It's very fragmented.
Then hospital in the home won't necessarily work in that context any better, because the expectations. I mean, it would be nice to think that the expectations on hospital and home would be higher because the patient is at home in terms of that. And to be fair, in some circumstances, because patients who come to hospital and home are a little more stable, they probably don't always have that need for ongoing coordinated care, integrated care afterwards. But to the extent that they do, they're subject to the same problems, issues, and linkages that are in the hospital. So I'm not going to pretend to you that suddenly having a hospital and home will fix all of that. It won't. But the hospital and home unit is subject to the same requirements to undertake that care, to undertake forward integration, forward referral to appropriate services as you would have in the hospital. And that's without integrating it, that's without changing the nature of where it lives. And I think in some ways it's preferable to have it on this side of the tent, on the hospital side of the tent, still subject to the same integration issues that happen automatically, but they're not. It's not. We won't solve. There are some problems people expect us to solve because we are at home. Some people think we will cure elderly patient frailty. We're not going to do that. Just because we're going and treating frail elderly people at home, we're not necessarily going to help every elderly frail patient forever. We can't do that. But we certainly can help hospitals look outwards more, and in doing that, maybe in looking outwards more, the links with community-based practice will get better.
Thank you.
Okay.
Thank you so much, Dr. Montalto.